PEWS is the Irish Paediatric Early Warning System, designed for use in all inpatient paediatric hospital settings. At its core, PEWS improves patient safety by enhancing individual and team situation awareness and promoting early action to mitigate against a child's potential clinical deterioration.
The main improvements of the new charts are that they bring together several features that were probably there in many places beforehand, but they weren't brought together in one chart format.
PEWS involves the use of a standard observation chart with a colour-coded scoring tool, escalation guide for clinical response, a standard communication framework, and documentation recommendations. Parent or family concern plays a significant role, along with the clinical judgment of the nurse or doctor. PEWS as a safety system is endorsed by the Irish Department of Health, the Health Service Executive, and the Royal College of Physicians of Ireland. The National Clinical Guideline No. 12 provides the policy framework and specific recommendations for successful implementation of PEWS. PEWS is designed to make hospital a safer place for children and to better support staff in caring for deteriorating paediatric patients.
The whole purpose of PEWS is to facilitate the identification of a child who is deteriorating. And that requires, I suppose, a cultural shift where people aren't afraid to speak up. If people have concerns, it's really important that they feel safe and empowered to speak those.
5 standard observation charts have been developed based on the best evidence of hospitalised children and are known as track and trigger charts. This means that the clinician tracks the patient's observations, and if a predetermined threshold is reached, a response is triggered. The type and urgency of the response is dependent on the clinical concern, but more about this shortly.
An abnormal respiratory rate is exactly that. It's a one-off abnormal respiratory rate. But as a clinician, as a doctor, it's the trends that help myself and my nursing colleagues to deliver better care. And so the trends over a shorter or longer period of time actually provide a much better picture than a one-off measurement. And so in interpreting PEWS as a system, it's all about the trends over a period of time, whether a child is deteriorating or improving. And that's why it works, because it allows us to identify the child earlier and offer us an opportunity to intervene.
The PEWS chart incorporates a specific A, B, C, D, E layout, reflecting clinical assessment priorities. The colour-coded scoring system assists clinicians to recognise trends in the child's condition. This is achieved by displaying the observations with dots rather than a number, which are then joined by a line. By trending the observations, it is easier for the clinician to interpret the child's clinical state and escalate care.
PEWS gives staff on the ward great situational awareness of the acuity of the patients on the ward. It's an easy system to use. Any nurse or doctor on the ward is very aware of the patient's current status, and it works really well.
There are 5 age-specific charts: 0 to 3 months, 4 to 11 months, 1 to 4 years, 5 to 11 years, and over 12 years. The PEWS charts are used for all children up to their 16th birthday. Each age group is distinguished by the age-appropriate logo on the front page. Apart from this, the front and back of every chart remains identical. There are 4 elements to the front page of the chart. There is an escalation guide to actions following a PEWS score trigger, a prompt to follow the ISBAR communication framework, and the Paediatric Sepsis 6 tool to aid recognition and early management of sepsis. Each hospital will decide the final element of the front page. This may be a section for permitted modification of the escalation guide or a record of significant clinical events. The back of the chart includes the respiratory assessment guide that assists a clinician in categorising the severity of a child's respiratory distress. Further contents of the back page and any additional pages are customised by the local hospital governance team. On the inside, the charts have been designed for each specific age group. Respiratory rate, heart rate, and blood pressure increments differ on each chart to best represent the agreed thresholds for each age group. The first time the chart is used, apply the 3 addressograph labels or write in the patient details. Complete the start date and year. Record the planned frequency of observations. This will depend on the clinical condition of the child and their underlying illness, and reflects a process of clinical judgment on behalf of the nurse and clinical team. Then, each time the observations are assessed, record the date and time, nurse initials, and NMBI PIN. Student nurses should comply with local signature policy. If there is a change in the child's condition, or if there are new directions from the medical team, or as a response to an increase or decrease in the PEWS score, the reassess within line below the total PEWS score is completed to reflect the clinical judgment of the observing nurse. The 6 core scoring parameters are assessed and recorded every time for every patient. These are highlighted on the chart and are clinical concern, respiratory rate, respiratory effort, oxygen therapy, heart rate, and conscious level. Additional parameter measurement is determined on a case-by-case basis for an individual child and will depend on the presenting condition, treatments and interventions, and on current and predicted clinical status. Some additional parameters carry a score. These are oxygen saturation, blood pressure, and central capillary refill time. The final parameters are skin colour and temperature. For example, in an infant with bronchiolitis, it is appropriate to include an oxygen saturation measurement in addition to the core 6 parameters. In a child with a heart rate that is abnormal, it may be appropriate to assess blood pressure and central capillary refill time. A sustained high respiratory rate or heart rate or abnormal temperature should prompt consideration of the Paediatric Sepsis 6 on the front page. During assessment, include the parent or carer in determining what is normal for their child and what may have changed. For every admitted child, record baseline observations on admission and thereafter at a frequency appropriate for the child's clinical state, whenever staff or family members are worried about the child's clinical state, or if the child is showing signs of deterioration or just not improving. Follow the example column on the chart when recording observations. Some are numerical: the litres of oxygen, oxygen saturation, and a capillary refill time more than 2 seconds. The rest are recorded with a dot joined by a straight line. This allows clear trending that can pick up small changes in the child's condition. Remember, in paediatrics, small vital sign changes can signal significant clinical change. The respiratory rate, heart rate, and systolic blood pressure numbers are also written to give specificity to a recording. Use the dedicated line for this so that the trending is not disturbed in the graph. There is a defined area for completing level of consciousness using the AVPU assessment. This is documented at every patient assessment except when the child is deemed to be safely asleep. That is, there are no neurological concerns and should be recorded like this. Clinical concern is a core scoring parameter in PEWS. Concern may be expressed by the clinician or parent or family member. Parents and carers know their children best and can be acutely aware that their child is unwell or just not right, sometimes before the physiological parameters become abnormal. Parent or family concern is a significant clinical indicator of deterioration and may require a greater degree of escalation than the score alone might indicate in the escalation guide. An assessment of parent concern is recorded with every set of observations. To enhance the validity of the score, parents and carers should be engaged in this assessment. A suite of resources especially designed for parents and staff using the Irish PEWS is available and is recommended for use in all areas.
My children have a rare condition, so oftentimes they fall outside the normal parameters that would be represented on charts and things in hospitals. Oftentimes it is the parents' input in a situation like that that can be extremely significant and is often not validated and has previously not been validated. But with this, you get that validation because there is a clinical significance placed on the parental concern.
Now that the observations are recorded, let's look at the 4 distinct colour zones within the PEWS charts. The white zone is considered the acceptable zone. That is, most patients trending in this area are considered to have acceptable vital signs. Nevertheless, it is important to be vigilant. For example, a heart rate that is steadily rising or sitting high in this white zone should trigger attention before crossing into the yellow zone. Each of the 3 colour zones represents a score of 1, 2, or 3. Every time a set of observations is recorded, the individual parameter scores are assigned and totalled. The sum of the individual scores represents the total PEWS score that is used with clinical judgment to guide care. The yellow zone is the first zone to signal that the child may be deteriorating. Every yellow box scores 1. The blue zone is the second and more concerning zone to trigger and scores a 2. In the pink zone, this is the most concerning zone and requires urgent response. This triggers an individual score of 3 and is potentially a very serious event. All PEWS triggers should be referred to the nurse in charge of a shift or area to decide whether a medical review is required. Some, but not all children triggering PEWS scores will need a medical review, and if requested, this should occur within 30 minutes or sooner. The doctor undertaking the review will clinically assess the child, communicate with the parent and bedside nurse, and document any changes to treatment in the child's healthcare record. There will be occasions when an experienced nurse or nurse in charge is confident that the child does not require a medical intervention or review. In this special situation, the decision is documented, and the bedside nurse may continue to observe the child and initiate simple comfort measures or administer prescribed medication, for example.
It's a very clear framework to say what the problems are, and it is very much empowering to be able to, ring somebody, contact somebody and say, I have concerns, these are my concerns. Using the ISPAR programme works really well in conjunction with PEWS as well. So yeah, no, it's an excellent situation to be in now.
The PEWS chart and score is specifically designed to enhance the identification of trends in vital signs. It is important to watch for worsening trends or no improvement in trends and escalate these. The PEWS Escalation Guide is used to inform action in the case of any PEWS trigger. It details the level of escalation required and appropriate timeframe for reassessment.
It gives a very clear framework for what response is appropriate to any child's condition.
Clinical judgment is essential when interpreting the escalation guide. It should never be used to reassure or step down care if there is clinical concern. All hospitals have agreed an urgent PEWS pathway that is activated if a child has a score of 7 or above, or about whom there is significant concern. Remember, regardless of what colour zone the observations are in, or whatever the total PEWS score, if you are ever worried that a child is deteriorating, initiate your local urgent PEWS pathway or emergency response.
We know that clinical judgment is a very powerful tool that helps us make good decisions, and if people have that sense that the only thing that's telling them there's something going wrong is their clinical judgment, well then they should trust that.
Clinical experience and clinical judgment are used to enhance the PEWS score and the escalation guide. There may be situations where escalation to review is not clinically necessary. We have described the special situation where an experienced bedside nurse or a nurse in charge may decide that additional medical intervention is not necessary. In other circumstances, a senior doctor may decide that a variance order or modification to the scoring parameters or escalation guide is appropriate. Let's now look at an example of a modification to the scoring system, a parameter amendment. A child with a condition that permanently, or for a fixed period, alters their baseline physiological parameters from the expected baseline for age may have a parameter amendment put in place. For instance, in a child with cyanotic cardiac disease, the oxygen saturation parameter range may need to be adjusted. The child's observations are then scored as 0 if they fall within this new range. Any value outside of this specified safe range is treated as a single pink or 3 score, and a medical review is advised. The medical escalation agreement box is provided to allow for a temporary modification to the escalation guide for an individual child during an acute presentation, if appropriate. It is only appropriate to consider an adjustment to the medical escalation if the child is determined to be stable, and then only for a short period. The reviewing doctor, who must be at least a registrar, should record the impression and rationale for the new agreement and assign a safe, individualised range to the selected parameters.
When the medical escalation agreement is made, it's made in discussion with the medical team, the nursing team and the parents of the child. So this is an agreement that they recognise the child is currently unwell, but there is going to be treatment administered to the child, and the child is expected to respond within a certain time frame to that treatment and improve overall.
During the time period covered by the agreement, The bedside nurse will continue to record the value of the observations in the correct position on the chart and calculate the PEWS score as usual. The senior doctor may modify the agreement for up to 24 hours, but only if the child is first determined to be clinically stable. Modifications should be used with caution. However, with appropriate use, they can be a valuable tool to anticipate care of the unwell child. For example, an infant with bronchiolitis would be expected to have an increased respiratory rate for the first couple of days of illness. In all situations of deviation from the recommended actions in the escalation guide, you must engage with the child and family, document all decisions clearly, escalate concerns quickly, and monitor closely for complacency and safe use of care. The introduction of the Irish PEWS was designed to make it safer for all children admitted to hospital and to make it easier for clinicians in recognising and responding to deterioration. Here is a quick recap. Show the trend by plotting the dot and drawing the line. The white zone is the acceptable zone, but you must stay vigilant. In the yellow and blue zones, speak with the nurse in charge and decide whether a medical review is required. In the pink zone, you must initiate escalation of care to the medical team and consider an emergency call or urgent PEWS call. The PEWS score and escalation response is always documented. Modifications should be used with caution. However, with appropriate use, they can assist the clinician to anticipate care of the unwell child. Finally, you must be familiar with your site's procedure for how to call for help, who can modify parameters or the escalation guide, and how to escalate care. PEWS is a toolkit for patient safety, intended to complement clinical judgment and enhance situation awareness. Cases should be considered individually and, where necessary, discussed with a senior or more experienced colleague. If you are ever in doubt, initiate the urgent PEWS response or dial your hospital's emergency number. So that's it. Allow PEWS to help you to care for admitted children safely.